Perfect. There we go.
Now I got it. Okay, we're good.
Hello, guys. Today's guest is Dr. Cooper, a primary care physician with Geisinger Health, who practices at the front lines of patient care, where clinical decision making, continuity, and long term patient relationships all intersect. I've had the opportunity to shadow Dr. Cooper extensively, and what stood out to me is how he approaches medicine beyond just a diagnosis, consistently integrating patient context, subtle clinical details, and longitudinal thinking into every single encounter. Watching how he builds differentials from incomplete information and adapts in real time has been an influence on how I understand clinical reasoning today. In this episode, we're going to dive into what primary care actually looks like day to day and how physicians think through complex and evolving patient presentations and what it means to manage health over time rather than treating isolated problems. So to start off with my first question, Dr. Cooper, we're going to keep it a little bit general. What made you choose family medicine in a system that often pushes specialization? And what did you see early that made you commit to family medicine?
Yeah, good question. So I think I have two answers for this. So the first is that I was very fortunate to live within 10 minutes of Hershey Medical Center. And as a high school student, my school had a program where I could shadow for the last two periods of my school day, junior and senior year. Junior year, we got a week in a whole bunch of different clinical specialties of medicine, nursing, patient transport, sterile processing, you name it, all throughout the hospital. But family medicine really stuck with me just because it was like every patient was something new. It was exciting. It made me think. I found like it was a challenge, and I like that. Um, and then my senior year, I spent half of my senior year shadowing primarily one family physician when he was teaching or doing other things. I was with a few other core group family physicians and just loved it. During that time, the physician I was shadowing was intentional about trying to get patients scheduled back at the same time when I would be there. And I got to see just within that 6 month period the value of getting to know people over time. This was a physician who'd been practicing there for about 20 some years at that point and really knew his patients well. They really trusted him. And there were several people who I got to see multiple times during those 6 months, both for sick and well visits, and seeing that he could address multiple aspects of their care and really understand them on a different level because of that longitudinal basis of the care really stuck with me. When I was in medical school, I was one of those people who realized that I liked just about everything. I liked surgery. I loved procedural medicine. Didn't really love the like dog eat dog OR environment. So just kind of ruled that out. Was also thinking about what I wanted my job to look like long term, and wasn't so keen on not knowing when my day would end. If a case would run long, or the OR schedule would get behind, and then potentially missing things for my kids in the evening or things like that. Um, at one point, I was like, man, I really love dermatology because I got to do all the office procedures and things like that. And then after a month of it, first 3 weeks were great. And the fourth week, I was like, okay, I'm kind of getting bored already. So I loved the variety that could keep me engaged. I love that every day is something different. One day I might see more kids. One day I might see, I did a day last week where I saw four people that were older than 95. And everything in between, I get to do office procedures. I get to teach. Both medical students, residents, and pre-med students. So I love the variety, but I love the ability to be there for a patient and their family, and kind of seeing how the family and community dynamics play out in their care too.
Yeah. You talked about valuing the long-term relationships, looking at the longitudinal aspect of patient care. What have you learned in seeing people over time that you can't really get from just an episodic situational care? And
Yeah, so
kind of
I think
seeing patient in this one context. Yeah.
I think I can have a little bit more direct conversation with patients. They know me, and that's the value of knowing them over time. They've chosen to come back to me because they appreciate the care that I provide. And you're not going to hit it off with every patient. Not every patient's going to appreciate your style. If that's the case, they'll find someone different. Everybody practices medicine a little bit differently, and that's the beauty of it. There's clinical guidelines, there's best practice, but then the art of medicine comes in and how that's delivered. So I think when you get to know people over time, you can press them a little bit more. Sometimes you get the impression that people just want to say what they think will make you happy. And you can see through that when you've gotten to know them better over time. So, whereas if I hadn't met them before or didn't know them, it's different. And I think we see this a lot when our patients are discharged from the hospital and they can be really sick. If they have a lot going on and you've never met them before, it is easy to not know what their baseline is, not know whether you can assess whether they've made a good full recovery or not. But when you know what their baseline was from when you saw them a few months ago compared to a change now, you can step in and you can potentially avoid a readmission back to the hospital when you're seeing, they're telling you things are good, but really you're like, oh no, this is a change. You walked in here on your own last time and you had to get pushed in a wheelchair this time. So, or hey, I see that you're using a walker, but you're really not that steady yet. So I don't want you stopping the home health yet that you don't want coming into your house. So things like that.
Okay. Yeah, I noticed this happened a lot during our time, well, my time shadowing you. Patients would come in and they would have like 20 to 30 different things they wanted to say. How did you kind of pick which things were valuable or important, which things were kind of just extraneous and didn't really need a primary focus during that 15, 20-minute patient interaction?
Yeah. So a couple ways. I don't think I ever go into a room without the goals that I want to achieve in the visit because I want to make sure that the important aspects of their care are being addressed. But everybody comes in for a different reason and they have their agenda too, and they want to make sure that their concerns are heard. So trying to start out with open-ended questions, trying to lead the conversation a little bit based off of what they told the nurse, because that's usually what their biggest concern is. And they're not going to really hear much of what you have to say or ask until their concern has been asked. So, trying to get what their concern is first, if possible, tying that into the concerns that you might have that you want to make sure that you're addressing during the visit. And that might be touching on chronic conditions they have. Are they feeling any rapid heartbeats if they have atrial fibrillation, or are they noticing any swelling in their feet or ankles if they have heart failure? Or hey, when you lay back flat, are you getting short of breath? So, kind of trying to get my points that I want to make in at different points in the question and trying to tie that back to their concerns is important. Um, when people come in with a list, it happens, right? I have a physical once a year, and if something's not urgent, I'll wait for that, right? And I'll bring it up when I'm already there. But if people come in with too many things, I try to say, hey, let's focus on the first two or three things. If we start to try to do too much, we're spreading ourselves thin and we're not really covering any one concern well, to the way that I would feel comfortable covering it. So if we need to, let's focus on the priorities and table some for next time. And I can get you back sooner to address those than we would otherwise.
Yeah. I think one of the major things that you've taught me, just seeing different patients, is that a lot of times the factors that are your outside of your direct kind of, what's the word? The factors that are outside of your control are oftentimes have bigger determining factors on how patients move with their disease or with their treatment. Right. So
Yeah.
when these guidelines and these patient preferences and these life constraints don't align with how a patient should actually be adhering with their treatment, what do you do? Like, how do you move forward from that? How do you cope with that situation?
Yeah. So I think we're in a weird time right now where patients are often more inclined to listen to the person that they hear on TikTok than maybe they are to their own doctor. And that depends on the person, right? So I think older patients they really just want to hear what the doctor has to say. And yes, they want to talk about it, but ultimately they want to know what you want them to do and they'll do it. And there's some younger folks that have already kind of pivoted back that way, where they come in and they look at what ChatGPT says about their concerns. And when you say the same thing that ChatGPT just told them, like you're gold, and they're going to do what because you're affirming what they kind of thought coming into. So I love when people take initiative to look things up on their own. I never shame people for going to Dr. Google or Dr. ChatGPT. But the information that they get back, people can't act on. Oftentimes, if it's something beyond just like a pick up over the counter treatment or how to treat a wound, um, and they don't know what a lot of that means, right? So if they're being told that they might have some scary diagnosis, part of what we might do is act as the interpreter for what the computer says or what the internet says, and help them to either affirm what they're concerned about or actually, here's what that might say. And a lot of these AI medical search engines are rather self-affirming. So if you lead them in a certain way, they will affirm that in one way or another. So um, I think that yes, there's clinical best practice, right? So evidence-based medicine has been the bedrock of medicine now for decades. Um, and I think for a while we were kind of straying further and further than that as social media influencers and whatnot were taking precedence over what science would say is best. And I think that that trend has really kind of worsened over the last decade. However, as people are able to look and they're able to get evidence-based guidelines, and a lot of medical journals are integrated into ChatGPT and other publicly facing AI software, they are starting to adhere more to these guidelines because that's what they're being told online now, if that makes sense.
Yeah, definitely. Another thing that resonated with me is that you mentioned that you were inspired by patients making difficult changes. While I was shadowing you, we saw patients who were medication adherent, and they put a lot of effort into their care and how they wanted to like improve their health. And then you saw patients who had a lot of external factors that were going on, and they couldn't put as much emphasis into their health, or maybe they didn't put as much care into it. What really separated the what really separated the people who successfully changed their behavior from those who still struggled and didn't put as much emphasis?
Yeah. So um, I'll preface my answer with I see a very small sliver of someone's life, and I only see the part that they bring to the exam room. I don't see the financial struggles, though, working a second job that I'm not aware of because they're in their 60s and embarrassed that they're not financially independent, things like that. So I think the people who are successful are the ones who really know that they have to make the change. Um, a lot of people know they have to make the change. They're not really sure how to do it. So when they're ready to make the change and we can coach them through that, whether it's giving them an app to use as a guide for their diet, or hey, I know you can't get to a gym because of your work schedule, but here's how you can fit like 10 minutes in 2 or 3 times a day just through YouTube, or things like that. I think um, really it has to do with just being ready. This could go with weight loss. This could go with people who are changing their diet because of diabetes and getting their sugars under control. This could go with smoking cessation. Um, and I am not going to, a lot of what I do as a family doctor is steering the Titanic, and it's not going to turn in a day or one visit or probably 3 or 4 visits. And I think the more turnover there is with who someone's primary care physician has been, the longer it takes them to trust you. So the longer that you have been their doctor, the sooner you can start to steer the ship.
Yeah. You mentioned something previously just now about smoking. I know there's kind of like this taboo kind of idea that doctors kind of speak to patients harsh about things like weight loss and smoking and lifestyle. How do you go about those patient interactions when people already have like these preconceived notions about what a doctor thinks is a healthy lifestyle and what they're going to say to them to kind of move towards the right direction?
Yeah, I think you probably heard me say this a few times, but I talk a lot about family members. So I am not someone who has ever struggled with weight. Neither of my parents did, both of my parents. And there's absolutely a genetic component to weight. Um, but they both, were someone who exercised on a regular basis too. That's how I grew up. I grew up thankfully with parents who ate well and modeled good eating behavior. So due to, genetics or due to modeling from my parents, weight's never something that I've struggled with. But I have people on both sides of my family who are pushing 400 pounds, that are severely obese, that have diabetes, that have weight associated medical problems, early joint replacements, all kinds of stuff. And so I try to speak not only to what should they do, but also here's what I've seen work or here's what I have seen not work. And then try to blend that with here's what science says. And I try not to say the evidence. I try not to, sometimes I'll say research, but here's what the science studies show would be most effective. And if I can blend that personal experience with the what the evidence-based medicine would show, that's the approach I try to take. And I also try not to set unrealistic expectations. I know that it takes on average 8 times for someone to quit smoking before they're successful. I let people know that, like, I don't expect you to come back next time and haven't quit. If you did, you're going to get a big high five. But don't be ashamed if you come back in 6 months and from the same position, and I'll be here for you regardless.
With the change in direction, I want to focus a little bit on inclusivity. We have a focus on the LGBTQ plus, on LGBTQ plus care and PREP. What are the common gaps that you see in the healthcare system, and how do you approach these populations?
Yeah, so I think one of the beauties of family medicine is that you can be a jack of all trades, but still have your own little niche specialties. So when I was in residency training, I kind of sought out learning opportunities to care for LGBT individuals through whether it's through sexual health, through things like PrEP for pre-exposure prophylaxis for HIV, through gender affirming care with hormone treatment. And I look at that as just kind of part of primary care, right? So someone shouldn't have to go drive hours and hours to go find a specialist to do these things because they're really not hard, right? So treating diabetes is harder than gender affirming care. It's heck of a lot harder than prescribing somebody PrEP after you've checked a couple STD screening labs and liver and kidney function. But these are things that unless you learned it during medical school and it was part of your curriculum, or unless you learned it in your residency and as part of the curriculum or you sought that out, you might not get it. So that's where being a lifelong learner comes in. And I try to look at what are the needs that aren't being met in my area. What are ways that I can try to meet those needs? So that might be learning point of care ultrasound. That might be learning to do certain procedures. One thing I'm exploring now is whether or not I can get credentialed to do Botox injections because I have at least a dozen patients with pretty severe cerebral palsy that travel a good ways to get Botox injections from a neurologist to help with some of the muscle contractions that they have that worsen over time. So if I could do that here 5 minutes away from home as opposed to making it a full day trip, that would be providing good care. So I don't necessarily look at that as like equity or each population. I just look at that as some people need knee injections and some people need moles taken off their skin and some people need pap smears and some people need PrEP. So and you just try to get your clinical interest to align with the needs of the population you serve.
You mentioned physicians who aren't trained in these areas. How do you think that we can go about getting physicians to actually be trained in these areas and to improve health outcomes?
Yeah, a lot of it's just student advocacy. So if you look at a curriculum that a med school has, and you might not have access to the details of the full curriculum, because honestly, there's kind of the full, a lot of this gets driven by board exams, and more of these questions are popping up, about, PrEP, about, a little bit about gender affirming care in boards, but for the most part, what's been on the board exam has not changed in a couple decades. The evidence has evolved, and that's evolved with it. But I think students asking for these things in the curriculum and then finding where they work, things like this don't always fit into little blocks. Could it be in the endocrinology block? There's no family medicine block in the preclinical years, right? There's a gastroenterology clerkship or a block. There's a pulmonology block. So some of these little things don't fit into a nice little block like that. So finding where it could fit into the preclinical years and in the lecture setting, and then really trying to find, students don't have a ton of control over where they get placed for their different clerkships. So if you're not put somewhere during your third year clerkship your second to third year clerkship that allows for that, seeking those things out during the fourth year, during your elective time is important. Same thing in residency. You'll have elective time. Make sure you seek those things out if it's not already built into the curriculum.
I think that's a very good solution. Moving to a systems kind of approach and kind of looking at primary care in a little bit more of a holistic way. You have a background in leadership and health policy. Where do you think primary care is currently failing patients at a system level? Like where can primary care kind of improve to kind of help patients?
Yeah, I think there's a focus on like there are physician shortages across the board. They're most acutely felt in primary care, in psychiatry, in some of the historically lower paying specialties, although that's not always the case. I mean, I can say as a family physician that I make within $20,000 of a year of what one of my co-residents' husband makes, who's a vascular surgeon at a well-regarded academic institution, who did 5 years more residency training than I did. So it's not always, the classic that the surgeons get paid more than the family physicians or the things like that. Supply and demand is starting to play a role. And if you go into family medicine, you're a hot commodity. So that being said, you're going to work hard and there's going to be a need. And, I can't tell you the last time I had an unfilled spot on my schedule because there's always more people trying to get in to be seen. So I think the focus on balancing the volume of people that need your care with sufficient time to provide good care so that you're not just turfing referrals. That I think is where we're stuck right now, in trying to allow more time for people who need it. So that because every time you see someone, they have a copay. Every time that they go to a specialist, they have an even bigger copay. That's time outside of work. That's time away from watching kids or whatever it is that somebody does during the day. So I would say that's probably the biggest disservice right now that I would see. There's also kind of this looking at healthcare economics of things. Everything in healthcare is determined by the government in reimbursement. So if you actually look at inflation adjusted reimbursement for services, we really haven't gotten paid any more since like over the last 20 years. Primary care, especially inpatient hospital medicine has gone up, but outpatient really, primary care has not. So that being said, compensation's gone up, the cost for the clinic nurses has gone up, the cost for health insurance has gone up. So I think we need to shift some of the value and the healthcare dollars that are spent, away from things like drugs. And the cost of drugs is going up astronomically. We spend very, very little upfront on primary care. We spend a ton, and I've seen different numbers, but a lot of them kind of are somewhere around 30% of healthcare dollars are spent on the last 30 days of life. So if we even just shifted 1% of that, or 5% of that up to the rest of someone's lifespan, think about how much healthier and how much better off we'd all be.
Yeah, you kind of touched on like two or three different things that could possibly be changed for healthcare and primary medicine in general. If you could pick one to change, right, and one you think would be the most beneficial, what would you focus on?
That's tough. I don't know if I could pick just one. And I don't know, and I would pick something that I would actually be able to change. So, I think how we look at our healthcare dollars spent, I think is I think it would start with reining in drug costs, because so many people are afraid to use their insurance, even if they have it right now, because they're all high deductible plans. And they're moving to high deductible plans because all it takes is for one person to be put on Ozempic or one person to be put on Humira or Dupixent or any of these biologics, or the GLP-1s that are thousands of dollars a month for people. And healthcare costs are just going to skyrocket for everybody else because the insurers need to make a profit. And when you've got one arm of I kind of think of healthcare as a three-legged stool. And when you have, one leg that is the healthcare delivery system, the hospitals and the clinics, and you've got one leg that is the insurance side, and you got one leg that is the, medical device and pharmaceutical companies. Those legs are not in balance, and the delivery side is very constrained. It's very restricted in terms of relative value units, and it has to be, net zero whenever they adjust the RVUs, what each service gets per RVU. The insurance side is constricted because they can't have more than a certain level of profit. Now they get around that by donating excess profits to their own foundations, and then they buy seats on hospital boards, and it's a whole mess. But there's really no restriction on what pharma will charge. It's really just what insurance will pay for. So I think if there were ways to shorten the patent periods, to stop extending the patent on these drugs, Humira, I mean, you can look up that one. Every time they get a new indication for it, the patent extends. Every time they switched it from preservative to preservative-free Humira, 2 more years on the patent, right? So I think if there's ways that once these medicines that really are taxpayer funded, these companies aren't going out and making these drugs from scratch. They're looking at what usually starts out as NIH funded university based research that gets spun off into a company that then gets acquired. I think if we could control costs that way, it would help bring down or at least slow the rise of insurance costs. People could move back to a more standard, affordable, being able to afford to use their insurance if they're lucky enough to have it, and then not delaying preventive care. That was a long answer. Hopefully that makes sense. So
Definitely does make sense. And kind of speaking on insurance and its relation to how you practice. And I know, I know in medical school, there's not really a primary focus on insurance and some of these things that have a big impact on you actually advocating and caring for your patients. In that kind of realm, what is something that patients don't realize about what goes into your typical day?
I think in my day, my work doesn't stop when the patient walks out the door. I need to make sure that my documentation is complete. It justifies the care that's provided to the insurance company. I need to make sure and I don't always have control over what I can prescribe, right? So, ideally, every insurance company would pay for what evidence says is most effective for them, but oftentimes they'll pick like one drug per class, and that's the one that I have to go with because that's what their insurance covers. So I think the days of here's what the doctor says, here's the paper prescription, go buy it, that's kind of gone. So sometimes there's a little bit of even down to the subtype of insulin that I use for a patient. So I can guide it, but then based on what their individual plan will cover, really dictate some of that care too.
Something specifically that I found interesting. Um, how do you manage your cognitive load? Like I know when I was chatting, we would see a patient with a musculoskeletal issue, then we would see somebody with type 2 diabetes, somebody with hypothyroidism. Like how did you manage switching from things like mental health to chronic diseases and back to preventative care? How did you mentally switch with all of these different areas?
Yeah. So I think part of that is just kind of like trying to keep the mindset of treating the last patient as well as your first, so that you're not kind of letting yourself get worn down and rushing through and not thinking as broadly as at the end of the day as you did at the start. Um, Part of that is delegating. Part of that is using your nurse, using your front desk staff, using other people of the care team to make some follow-up phone calls or annotating what you might need in the moment so it doesn't get forgotten. And then I like that variety, right? So I think that for some people that can feel really overwhelming to think about different things. But if I only treated 8 or 10 different conditions my whole career, like I would kind of get bored. So that's just me, right? So I like that variety because it keeps me on my toes. Um, I think there's three main types of encounters for people. There's the routine follow-up of chronic conditions or preventive care where they're feeling good. They don't have anything that's going wrong. And my job is to affirm that there's nothing going wrong, either through what they tell me, what I examine, or what their labs and or imaging might say to pick things up early. There's the person who comes in with a simple, I'm sick, what should I do about it? Or I cut myself, how do I fix it? Kind of the quick acute visits. And then there's the people in between who come in thinking that they have a cold and really it's their COPD exacerbation, or really it's their heart failure, or the person who comes in with, hey, I think I cut myself because it's not healing and actually it's a skin cancer, or things like that. So recognizing when you kind of live in that gray zone of not everything is a chronic pre-diagnosed condition and not everything is something simple and acute, a lot of it is in that middle. I think the concept of the interstitium, which is that space between in the body, so it's in between two spaces. I think that's a lot of medicine where it's not cut and dry, and that's where the art of medicine comes in, and that's where you have to really be on your toes to decipher, is this what we think it is? Is it something different? Or if we have no clue what it is, how do we be methodical about directing ourselves down the right path?
I know you just mentioned preventative care. What do you think that the general population is still getting wrong about preventative medicine?
Yeah, I think the general population in general either wants to put their head in the sand and deal with it when they have symptoms, or they want every screening test known to man. I'll give mammograms as a good example. So there's been tons of awareness, wear pink for, in October for breast cancer. Susan G. Komen, American Cancer Society. There's tons of different awareness events, and that has really increased breast cancer detection rate. However, there are a lot of false positives and a lot of harm that is done through so many people having mammograms and doing detection. So I think having, at what point do you stop? At what point do you start? Um, Coronary calcium scores are another example. They don't really align that well with someone's risk. In theory, it should, but it doesn't always. So I have a neighbor who found himself, kind of now lives in Florida half of the year, found some concierge medical practice, and they're doing like all of these tests. And I'm like, what's going on with you? Why are you doing all this? Oh, I'm just trying to, get healthy. And it's like, so there's a lot of stuff that people either go, full bore, they want everything under the sun, or they want nothing. And really, it's especially with electronic health records being basically ubiquitous over the last 15 years or so, there's a lot of really big data that can drive what helps to keep people aging healthy, what saves lives, and what's not worth, what does more harm than good. So trying to communicate that in a way that people understand, I think, is where we really need to cut through, or we're not really doing a great job yet. But I think that's probably the thing that um, like there really is a lot of science behind this. And unfortunately, I think when politics and medicine get mixed, people then put their own interpretation into things that shouldn't be political and shouldn't be up for interpretation, when the science is pretty definitive in some of these cases.
Yeah. Still on the same track of preventative medicine, how early should we be intervening on things like obesity, mental health, chronic disease? I know these are three separate realms of
Mhm.
medicine, but in general, how early do you think that intervention should occur?
Yeah. So I don't think it's ever too early. I'll give an example. A kid I saw this past week. I take care of his mom. I take care of his older brother. He was there for his 12-month well child check. This kid is off the charts in terms of his weight. However, older brother and mom are too, right? So, like I said earlier, there's definitely 100% a genetic component to weight and to obesity. There's also kind of a learned component to how you eat. When the older brother comes in and he has a juice box, right? That kid doesn't need a juice box. He should be drinking water. So, um, I don't want to ever, I'm never going to call a kid obese who's 12 months old, right? But I try to then reaffirm with the parents, like, hey, he's really grown well. Here's how we can, because a lot of parents feel like if they're not feeding their kid when they're hungry, they're not giving them enough. And a kid's job is to grow. And if they're not eating, then they're not going to grow. So helping to guide, like, hey, here, let's see what he's getting throughout the day. How much milk are you giving him? Oh, okay, you actually don't need to give that much, right? It's 12 months now. You don't need to still be fortifying with formula. Switching to whole milk, you're right at that point where we should be doing that. Um, and kind of scaling back and just resetting expectations. Um, the number of people who tell me that they started smoking when they were 11 terrifies me. I have a 9-year-old daughter. I live in a town that still has a lot of people who smoke, but a lot of them started really young, because that's what their parents did. And that's what they did. And they kind of snuck it. And their parents said, don't do it. They still did, but they did. Now the same thing's happening with vaping. I just did school physicals this past month, and the number of kids who vape in sixth grade terrifies me, right? So I don't think it's too young to start talking about those things, but I have a
Mhm.
very small influence over people's health, right? I see them, once a year for a physical or however often they need to be seen when they've got other conditions.
Mhm.
But the nature versus nurture, um, I'll try to nurture, but I recognize that, I have a limited role.
Okay. Yeah. Speaking about kind of modern day and innovation, there's a lot of hype about digital health, wearables, and AI. What actually helps in clinical practice versus what just sounds good? Um, what just sounds good about it. The things that people say, there's a lot of things that are uprising with this general conversation. So
I think for me, you saw me use my AI scribe in clinic.
yeah.
I've been using it for over a year and a half now. I was in the first little 30-person pilot group at Geisinger to try this one out. I love that I can just hit record. It scribes the visit. I've had very few people who have said no to that, and I can not face my keyboard. I can face the patient. So I feel more engaged with my patients that way. I found that I end up talking more because I'm not trying to type down all the details as I talk. And I've enjoyed practicing medicine more with that. It doesn't really save me
Mhm.
much time. I still have to go through, it puts a lot, the more I talk, the more they talk, the more that goes in the note, and I need to review all of that. There's been a few early studies out on the impact of AI scribes. They don't really save much time. They improve the note quality dramatically. They improve the details that get in there and the details that don't get in there. They um, they do improve satisfaction with work and enjoyment for the physician, but they don't save much time. So right now they're trying to get us to see more people, and scribing was a way to do that. But it's just like it's I think we're feeling right now that this wasn't the Pandora's basically the end all be all of, hey, we're going to give you the scribe and we can then have you see three or four more people a day. So um, recognizing that, I mean, same thing with electronic health records, right? When they were rolled out, Epic, we've had Epic at Geisinger for 25 years. So um, it was supposed to save all this time. No, there's more documentation needed now. So technology is not always going to be a time saver. Hopefully, it improves outcomes. I'll
Mhm.
say like Apple Watches are great when someone has one and they say they have palpitations and they do the little EKG function, which is a single lead
Mhm.
rhythm strip. So it's not an EKG, but if it they can say, yeah, it's at AFib, like that's helpful because the check engine light usually goes off by the time they come into the office, right? Um, However, Apple Watches, I just learned this the hard way, but if you have a wearable device on that can do cardiac monitoring and you get an EKG, it will make the EKG look like you're having a heart attack. It will change because of the metal and the electrode, the detector there. It will change the direction of the electrical current on the EKG, and it can cause ST elevation. So um, so they can help, but we also need to be aware that they could have other impacts too. I mentioned earlier about the Chat GPT health and all these different ways that people use online. I think the more that medical journals and medical evidence-based medicine can be incorporated into those, I think that they actually can help swing the pendulum back towards more guideline-based care. So
Yeah. I really appreciate that. I want to kind of shift a little bit more to your perspective and growth over time. I want to kind of have you zero in. Have you ever had a time where you found yourself doubting this path that you're on, doubting medicine in general? And if you have, what were the steps that you took that help to keep you committed to this path?
yeah, I think sophomore year of college was the first time that I like struggled academically. I had a lot. I mean, I was very, very busy with courses and labs, and I was like, man, am I cut out for this? Like, if this is, but I have always been a good student, right? And this was the first time that I was really tested. I think leaning back on the fact that I had shadowed as much as I had and had that exposure and knew like, hey, I'm not going to love every step along the way, but if it
Mhm.
gets me to an end goal that I really like, it's worth it. And I need to just persevere. I need to change course in terms of how I'm studying or how I'm learning things or um, how I'm trying to engage myself. But yeah, and I think, and then second year of med school, same thing. I'm not sure why it was about the second year, but
Mhm.
when I was studying for step one and just like really not enjoying it and just sitting there and studying day in and day out and like really, I thrive on the interaction with people, not the sitting there and taking a multiple choice test. So those are hard times, but um, I think just recognizing that like that wasn't the end game and that's not what I was working towards doing the rest of my life, and that it was a temporary thing. You just have to kind of take a step back, see the bigger picture perspective, and keep working hard at it.
Yeah. So you just mentioned the progression from being in college and going to medical school. And I want to focus on your time in residency.
Mhm.
Um, right. So kind of during that time where you're formulating how to be a good doctor and seeing actual patients and having a little bit more responsibility, how has your perception and your understanding of what a good doctor actually is, how has that changed since your time in residency?
Yeah, I think there's what patients see as a good doctor, and really that's the communication. That is, do they understand what you're getting at? Can you explain why you have a plan? They don't necessarily know the clinical medicine, right? So I could prescribe a patient exactly what they want for their anxiety, but that might not be what is best for them. That might increase their fall risk, that might increase unintentional overdose risk, things like that.
Mhm.
So I think in my mind, the best doctor is the one who gets somebody to understand why what we know is best for them based on guidelines and evidence is what they want for themselves,
Mhm.
right? Not what you want them to do, but why you get them to come to, wow, yeah, this is what I want to do.
Mhm.
Um, there's lots of ways. The main one for to evaluate physicians is called Press Ganey. It's kind of like the Yelp review for doctors or the Google review. And it's the same. You get the people who are either thrilled and they have all the time in the world, so they're going to write up a nice review for their doctor every time they see him, or they're the person who's pissed off because they didn't get the antibiotic that they thought they needed, and they're going to give you a bad review. So, I my review this you worked with me. You saw how many people were very thankful for the care. I mean, you saw a couple people who left not getting what they wanted. But in a 3 month period, I had 10 people who filled out the survey for me for the first quarter of this year. And I got rated in the 15th percentile. Do I care? Not really. Do I need to start telling people, hey, if when they were happy, and just like they do with when the mechanic comes and you get, give us a 5-star Google review. No, I don't want to be self-promoting. But do we need to improve the denominator? Maybe. I don't know. It's in the end, you have to be able to sleep well at night based on the care that you provided for people. And
Mhm.
for me, that's what it means best to be a good doctor. So,
I definitely agree. I want to shift the focus to the upcoming generation, to the people who are coming up in medicine, people who are people who are pre-meds. A lot of people kind of overlook family medicine and look at the other specializations that have a lot more popularity in some of these spaces, right? So, um, what are they misunderstanding about family medicine, and what is the stigma? What do you think is contributing to that stigma?
yeah. So some schools don't even have a family medicine department. Most medical schools, most medical students spend their time in the biggest academic hospitals in the country,
Mhm.
and they see tertiary care for 90% of their medical education.
Mhm.
90% of healthcare in this country is not provided in tertiary care centers.
Yeah.
It's provided in clinics, it's provided in small towns, it's provided by telehealth to the person who can't get into the clinic. Um, so I think there is totally a disconnect between what medicine is and what practicing medicine is and how it is taught. Just because resources for that support a critical mass of physicians in one place to teach the next generation of med students are clumped in the largest centers.
Yeah.
So I think for that reason, people really should seek out clinical experiences outside of that big tertiary care center. Don't do a family medicine rotation right across the street. I say that, but then I did my residency at Duke, which is one of the biggest hospitals in the country, and I was right across the street from the hospital for my clinic, and I had a great experience. But seek out underserved rotations, seek out rural rotations, because you'll realize that wow, family physicians do a lot. I don't deliver babies, and a lot of places family docs do. There's a lot of places where the family docs are the ones that cover the emergency department or that do anesthesia or things like that because you're the doctor for that town and that's what the town needs you to do. Um, so look for those places. If your set third year clinical rotations don't allow for that, you have fourth year in med school is the most expensive vacation of your life. You're going to have a lot of vacation time that's meant for interviewing, but use that elective time to seek out these kind of rotations and do it early. Some places will let you flip-flop, third year core rotation with a third year, push that to a fourth year and do an elective up front in the third year to try to figure out what you want to do with your life.
Mhm.
Ask about that, because if you haven't had that chance to get out to one of these places where you can really understand what the breadth of family medicine is, seek that out.
Mhm. Yeah. Staying on primary care, if somebody wants to be an excellent primary care physician, right, as a pre-med student, what skills should they start building now? What should they start focusing on? What should be their mental thought process when it comes to just medicine in general?
So know that you'll never stop learning, know that you'll never know everything, and know that probably the most important thing is to know what you don't know.
Hmm.
Because when you know what you don't know, that's when you can ask a colleague, that's when you can refer, that's when you can reach out to somebody else.
Hmm.
I think learning to be a good communicator is good, learning to multitask is good, learning not just about the science, but learning about health communication, learning about economics. Because when 20% of the economy is healthcare, you can either be a cog in the wheel or a pawn in the system, or you can try to steer it for the better. So, um, learn a language. I was a dual major in Spanish and biology when I was in college, and I used my Spanish, I would say, 4 out of 5 days at work. Um, probably more so than some of the cellular biology, or getting into the nitty gritty biochem or physics. So,
Hmm.
um, try to spread your wings broadly. Try to learn a lot, and just know that you'll be a perpetual learner.
Yeah. So ending with a closing question. After everything we've talked about today, um, if you can give your younger self one piece of advice, whether that be yourself in residency or yourself in medical school or yourself during your college years, what is the most, I guess, foundational thing that you would tell them?
Oh man, one piece of advice. I don't think I'd change anything, right? So I think, I mean, I'm very happy with where I am. I think the advice would be just that recognize that it will not always be easy. You will not enjoy every step along the way.
Mhm.
But journeys are long, and there's sometimes hard, sometimes easy. But keep, don't be afraid to pivot, right? So if you really are not liking what you're doing, don't just push through.
Mhm.
Don't go into medicine for the money, because if you want to make money, you can go into business and make a heck of a lot more money, a heck of a lot faster with no debt, right? Or debt that's putting into equity for a company that you're building. Um, I think make sure that you're going into medicine for the right reasons. Make sure that you're doing something that you are going to wake up every morning being excited to do. And kind of going back to that dermatology thing, right? I love doing the skin procedures, but it's like I really see myself doing this for 30 or 40 years. And know that you have a gift that is special, and that really you almost owe it to your community to continue to use that gift. So there's some people who, like, I've worked hard, I just want to retire early and be done and burn out. But if you're feeling burnout, pivot, do something different, continue to use that gift in one way or another, because there's only so many spots for med school. There's only so many physicians we can have. And that's something that you have that few others do. And when you are in that room with a patient, um, I continually am humbled by the fact that people will open up to me about things that they have never shared with anybody else, and that happens on a regular basis. Like, what I do is pretty cool, and it's also a very humbling experience too.
Yeah. I just want to say thank you for this, for your time. I know you have a busy schedule. It's not always easy to take some time off and be able to do some things. So I really appreciate that. I appreciate you sharing all your advice, all the time you spend in medicine and all your experiences. It's greatly appreciated.
Yep, of course. Well, thank you very much. Good luck.
Thank you. All right.